Good afternoon, everyone, and thank you, Fiona, again for the kind invitation. And this talk, we are going to talk about the rat-path correlation, but before starting this, I would like to share with you some information about the NHS system in Italy. So we know that the Republic safeguards health as a fundamental right of the individual, as guarantees free medical care to everyone and also to the poor. And law may in no case violate the limits imposed by the respect for the human being. So this is the must. And from the law of December 78, we have three basic principles that are universality, equality, and equity. What does it mean? It means universality. It means that the extension of health service to the entire population. So the health has been understood not only as individual good, but also a resource of the community. For the equality, it means that the citizen must access to the NHS service without any distinction of individual, social, and economic condition. And all citizens also must be guaranteed equal access to the equal health needs. For the equality, we mean that all the citizens have this type of card. I hope you can see my arrow, in which, of course, we have surname, name, and in particular, a number that means it's a code. For this code, we can have this type of sheet of this type of paper that is called ticket, because direct healthcare service and medically necessary treatments provided free of charge, except for the co-payment cost of this ticket. That could be different, that is fixed by each region, but usually is not more than 50 euros. So we can pay nothing or maximum 50 euros to do everything and any kind of service. That means, in particular, I'm talking about this one, diagnostic imaging treatment performance. So the service offered by public health facilities or by facilities that are accredited with the Italian National Health Service. So we can have local health authority, public hospital, on NHS affiliated private facilities. And all these three ensure the essential levels of assistance. So this is called LEA. Okay, and the local health authority has a list of doctors that are affiliated with the Italian NSH, that are in general practitioner, or could be pediatrician affiliated with the National Health Service that can perform, for example, vocational consultations, or maybe prescribe specialist services, laboratory tests, diagnostic tests, medicine, or hospital admission. They can do all the stuffs. Usually the pediatric is take care of patients from birth to the age 14 years old. Between the age of 6 and 14, it is possible to choose between the general practitioners and the pediatrician. And usually the adult care is entrusted to general practitioner from the age of 14 upwards. This is the division. But what is working good and what's not? Here we can have, of course, specialist visit and diagnostic test that is, again, as I told you before, prescribed by NHS doctor. That could be pediatrician or general medical doctor, and they can have the access of diagnostic tests or laboratory in the health facility or private NSH as affiliated facilities. And this can be provided for free or maybe just with a payment of a ticket, co-payment of a ticket. On the contrary, for chemotherapy, oxygen therapy, dialysis, for example, is totally free of charge for everyone. For in the dental care system, we have some problems, because of course we can have the access to to the system with the co-payment of ticketed, but usually we have a very long waiting list. So for the part of dental care, the system doesn't work very good, okay? But what about breast cancer numbers in Italy? We know that the breast cancer corresponds to 1 in 3 malignancies in all the Italian female population, that is around 30%. And in 2020, we had 50,000 breast cancer new diagnoses. We have 12,500 deaths in 2021. So this is a large number. But the good news is that we have 88% of the survivals of 5 years. But of course, in the last years, we have a continuous decrease in breast cancer mortality since the age of 19. And it's mainly due, as you should know, by the mass screening programs and the technological evolution that promote the early diagnosis of breast cancer, such as non-palpable breast cancers. And because we know that if you perform an early diagnosis, we can do a more conservative treatment with the higher survival and mortality reduction. And in this table are shown the performance of the screenings around Europe. As you can see, Italy is not very good compared to UK or to Finland, Netherlands, and so on, but not so bad. We are in the middle. Okay. What is the cancer program, cancer screening program in Italy? We used to do one mammography between the age of 50 to 69 every 2 years. And since two years, something like that, we started, but just in some regions of Italy, to start to extend the screening between the age of 45 and the age of 74. But it's not the standard. So think about 50, 69 to every 2 years. What about ultrasound? Usually we don't do ultrasound in young women asymptomatic, means younger than 40 years old, and no in patient younger than 25 years old, also if is high risk. So we start after 25 years old. But why we have decided, and all the Europe have been decided to do the cancer screening program between the age of 50, more or less, to the age of 70. We know that the lifetime probability risk to developing breast cancer is about 1 in every 8 women, but its percentage is very low between the age of 30 or under the age of 30. It's just 1 in every 228 women. As you can see in this graph, you can see here the higher incidence of breast cancer in between the age of 50 to 70. That's why the screening program is between this age. But what about the pre-screening and the post-screening time? What are the clinical and biological features of breast cancer and the prognosis in these two patients groups? Does the diagnosis and clinical management differ between the two groups of patients? Let's see. This is a paper published in 2020 in which they compared 2 groups, younger group and older group. As you can see here, usually the younger group present a larger tumor size and higher stage. And it's typical, quite typical, that's something that you know, and this is mainly due to the absence of the screening settings, screening performance mammography on this time. But let's see this table. This is another paper, and it's quite interesting. This evaluated trends in breast cancer mortality by stage at diagnosis, and we can see here that the mortality of this patient, young patient, is not so high, also in case of metastatic cancer. But why? Because probably the significant reduction in the probability of dying for breast cancer among young women, should be due by the therapy. Because if the patient, this group of patients are typically not screened, the only result for the low mortality or not so bad mortality, it should be done by the treatment, I mean, chemotherapy, neoadjuvant chemotherapy, and so on. And it's something interesting. But going back to the paper that I showed you before, we can see here also that in the younger group, we can have usually more aggressive tumors such as triple-negative cancer and high-grade cancer. So the increased proportion of aggressive tumor subtypes in young patients is something that we know, but probably the new target chemotherapy and systemic therapy can erase the importance of age as a prognostic factor. And this is quite important because before we said that if we have a cancer in a young woman, there is a negative prognostic factor. And this is true because the tumor are more aggressive tumors. But now with the new therapy, it's not that bad in terms of mortality. That's something new. This is another very nice paper published in Journal of Clinical Oncology in 2011. And also they have divided patients in two groups, younger than 45 years old and older than 65 years old. And you can see here again, that the younger patients usually present HER2-positive and basal-like tumors. So they stated that the current analysis strongly suggests the biological difference present between breast cancer carcinoma arising at the extreme age of the age are strongly influenced by gene associated with intrinsic breast cancer subtypes. This is very interesting. But in terms of treatment programs, the decisions should be driven by the subtype biology and performance status and much less influenced by age. What does it mean? It means that if you have a patient with triple-negative breast cancer, younger than 45 or older 75, you should treat the patient in the same way, because usually we have the same type of triple-negative cancer. It's just more frequent in younger, but if you find this one in an older patient, you should treat in the same way. I said should treat. What about triple-negative breast cancer? We know that it corresponds to 10 to 50% of whole sporadic breast cancer. This is more frequent in young women, younger than 50 years old, as more frequently associated with BRCA1 mutation carriers. And this type of tumor is high chemosensible, but with worse prognosis. What about imaging of triple-negative breast cancer? This is a paper published in 2010 in which they evaluate the behavior of triple-negative breast cancer at mammography and at ultrasound. And here we can see that in general, at mammography, we have this tumor presenting as a mass. At ultrasounds, again, more frequently presenting as a mass, we have circumscribed margins, hypoechoic, and parallel orientation. This is a typical finding at mammography and ultrasound. And in this different paper, we can see what about MRI imaging, what about radiological features of triple-negative breast cancer. And they stated that the triple-negative cancer usually presents a mass lesion, 75%, hyperintense on T2, probably related to necrosis and negative prognostic factor, usually present per-lesional edema, rim enhancement, and type 3 signal intensity over time curve. And more recently, also with my group, we have published paper in diagnostic in which we try to evaluate if can MRI biomarkers predict triple-negative breast cancer, and we conclude that yes, because triple-negative breast cancer is associated with specific MRI features, and then we can use MRI as a prognostic, with a prognostic value. Let's see, this case is a woman, 36 years old, no breast cancer familiarity, and this is the screening mammography. What you can see, you can see oval opacity with regular margins, high density. That could be also a benign lesion at mammography, not particularly a sign of malignancy, but of course you should do ultrasound. At ultrasound, following the biopsies, we can see our lesion with parallel orientation, little irregular margins here. And this is the corresponding MRI examination. Here we can see high signal in T2, rim enhancement of the contrast agent administration, high signal on diffusion, and low signal on ADC map. So it's quite typical for malignant lesion, or maybe it could be possible triple-negative breast cancer, and we can assign a BARS4 to this type of lesion at MRI. So we perform a biopsy, ultrasound-guided biopsy, and it is invasive cancer, grade 3, as you can see also in this correlation with the path. We perform right upper quadrantectomy, and this is the corresponding, this is macro specimens in which we can see is the morphology as oddly correlated with the MRI imaging, also is this macro of the path. And we found a triple-negative breast cancer with a 45K67, 12 millimeter. This is another example, 33 woman, BRCA1 mutation. At palpation, we can have a volume mass on the left breast. This is the mammography. We can have a high density here, but visualize tomosynthesis, you can see here also with multiple microcalcification. And the contrast enhanced MRI, we can see here scattered enhancement, non-mass enhancement involving all the left breast. We perform ultrasound-guided biopsy, and it is a triple-negative breast cancer again. Again, diffuse, involving almost all anteriorly the left breast. So this patient was eligible for neoadjuvant chemotherapy. And this is the new MRI at the end of neoadjuvant chemo, and we can see that we have no enhancement at all at the MRI. So this is a complete radiological response at chemotherapy. So it is important to know that when we have a triple-negative breast cancer, this patient is candidate to neoadjuvant chemotherapy, of course. This decision should be done during the multidisciplinary DMGT. And this is the corresponding specimens of this patient. We can see no residual disease on the specimens, and also in the path, as you can see here, no malignant cells. So there is a correspondence between radiology and pathology in terms of response to the therapy. It's very important to remember that in this patient, young patient, performing chemo, neoadjuvant or chemotherapy, whatever, it's important to safeguard also the human fertility. In fact, it's important that now also in the multidisciplinary team evaluation, also to include a gynecologist expert in the human fertility. But what about the breast cancer in patients beyond the age of screening? We know that about 30% of breast cancer patients are older than 70 years. And mainly, this is a growing population. Latest data reported between 2000 and 2050, the rate of women older than 80 years old will triple in industrialized nation. So we will have more and more patients older than 80 years old. This is a nice paper published in Breast Cancer Research and Treatment, in which they evaluated elderly women with a systematic review. And again, they subdivided this group of patients in whole patient and whole patient between 1775 and older than 80. And we can see something very interesting. In this group of patients, the detection is mainly done by radiology, the tumor size ST1, and we have N0 as novel status involvement. On the contrary, in a patient older than 80, we can see their diagnosis in mainly clinical, the tumor size T2, and we have mainly lymph node status involvement, and sometimes also metastasis. But why? Because usually after the age of 70, we have less aggressive clinical and biological behavior of the tumor. But also, if the tumor is less aggressive, usually we detect the tumor at the advanced clinical stage, and frequently with the onset with metastatic disease. And mainly also the advanced cancers are relatively more frequent in patients older than 80 years old. But why? Because probably because we don't have the screening in this in between the age of 70, after the age of 70. And this is the mainly region, because if the tumor is less aggressive, if we have advanced clinical stage, of course, should be due to the absence of screening. And this is very interesting also, something regarding the treatment. Again, in this paper divided patient younger than 65 years, the age 65, 74, and older than 75. And you can see here, then after 75 years, the treatment in the majority of the case are mastectomy, no radiation therapy, and no chemotherapy. So we treat this patient just with mastectomy, with no other treatments, and also can influence the mortality of this patient. In fact, as you can see here, before the age of 75, the mortality is not so high. This is breast cancer, or other cause. But after the age of 75, of course, we have another number of mortality due to all causes possible, but you have also another number of mortality, other incidents of mortality due to the breast cancer. Not only in general period, this is not just only to the absence of screening and so advanced stage at diagnosis, but also due to the absence of the treatment. So before decided which kind of treatment should be performed this kind of patient, we should evaluate the comorbidity, nutritional and functional status, less application of standard care, and no adherence to the therapy, probably due to the social isolation, disorders, cognitive disorders, disabilities, and so on. So the current recommendation by the USOMA, all management decisions for an older individual with breast cancer should consider physiological age, life expectancy, potential risk versus absolute benefits, treatment tolerance, of course, and patient preference. So should be perform a very high collaboration between geriatric and oncology management. Strong collaboration with two specialists. And this paper confirmed what I told you right now. And for this reason, in many countries, the screening mammography is being continued up to the age of 75, and in some regions also in Italy. Also because in this group of patients, we don't used to do ultrasound and MRI for the reason that you probably already know. So the screening with mammography is very important. But let's see some cases. This is mammography. This is a irregular or positive with multiple microcalcification inside. And this is the corresponding macro specimens. And we can see here a very high correlation between the morphology of the lesion, the specimens, and the mammography. But this type of tumor that looks like very bad on mammography is a luminal pathology, typical of in the elderly patient. Again, another example, this is the mammography performed in 2017, reported as negative because should be also look like also an intramammary lymph node, for example. And in a follow-up 1 year later, we can see this irregular opacity with some microcalcification inside. And again, the morphology of the lesion and the macro is very, very similar. And again, is a luminal A. So more typical in this group patient, we have luminal A type of cancer. But what about DCIS? DCIS is more common also in an elderly patient, but is usually characterized by low grade and positive hormone receptor expression. This is a case, let's see this enlargement. We can see here, I hope you can see here, multiple clusters for microcalcification, and this all patient, and it corresponds at the specimens at on the low-grade DCIS, as you can see here, low grade. So if the CIS is more common in elderly patients, usually characterized by low-grade and positive hormone receptor expression, what about DCIS in young women? Here we have very dense breast mammography with high-density multiple microcalcification, irregular between one and the other. And at MRI, we can see this non-mass enhancement that involve all the left breast. And at pathology, we have high-grade DCIS and usually no expression of hormone. Another example, very dense breast in young women, again, multiple cluster or clustered microcalcification, segmental enhancement on the left breast and MRI, and again, high-grade DCIS with comedonecrosis. This is very typical. So we have a difference between one and the other. And again, although a comparison between young and old patients with triple-negative breast cancer has been stated, younger patients show more aggressive histotype, higher grade and proliferation index. Older patients were more likely to treat with mastectomy, less axillary surgery, less radiation therapy, and less neoadjuvant chemotherapy, told you before. And we have recurrence-free and distant-free was statistically most significant worse in older patients. But why? What I told you before is significantly worse because the absence of treatment, because we treat different triple-negative breast cancer in young and in old patients. This is not good. Because if we adjust for neoadjuvant and neoadjuvant chemotherapy, the difference in survival between the two groups, old and elderly patient, completely disappeared. So it just be done due to the chemotherapy. So going to the take-home messages, does breast cancer differ between young and elderly patients? The answer is they have in common pre and post screening age, that we detect the tumor in advanced stage because of the absence of screenings. But what does influence breast cancer prognosis? Two things, tumor biology and patient biology. More typical tumor in young patient, we have triple negative cancer and high-grade DCIS. On the contrary, in elderly patient, hormone positive patient and low-grade DCIS. But of course, it's very important how we treat this patient. So it's very important to discuss every patient in a multidisciplinary team. And in this team, we should include all professionals, figures to take care of all age groups that needs our treatment and our help. Thank you for your attention.